Thank you. My name's Kirsten, and I'm one of the pharmacists in the Saskatchewan Health Authority here in Regina. And I'm happy to talk to you about my project implementing electronic handoff in home IV patients receiving vancomycin. So the World Health Organization definition of transitions of care is on the slide, but put very simply, transitions of care are all the different points that a patient goes through during their healthcare admissions or when they're receiving healthcare services. And these points in care can be either geographical locations or different practitioners. And as was mentioned earlier, transitions of care are very vulnerable times for patients, largely because it puts them at increased risk of experiencing adverse effects or medical errors that are due to a myriad of reasons, but some common ones are really communication-related issues between transitions of care. So an example in Regina that ended up being the focus of my project was any patients who are prescribed intravenous vancomycin can at some point be initiated and admitted to the home IV vanco program, which is an outpatient, kind of an ambulatory care program. And so these patients, along with that being a transition of care, also have their drug monitoring completed by multiple SHA Regina pharmacists. So to help improve this transition of care process and reduce adverse effects that may occur, by December 22, the AIM statement is to achieve 50% documentation rate for pharmacist interventions when they're completing therapeutic drug monitoring for patients receiving vancomycin. So I've included the driver diagram here. We identified 4 primary drivers as well as a multitude of secondary drivers. But for the sake of a 3-minute presentation, I'll just focus on the primary driver communication, which is where we implemented our change ideas. So for the secondary drivers, we identified that standardized forms were only available in BDM, which is our pharmacist dispensing program. And what this means is that other healthcare providers wouldn't be able to see any of our rationale for drug dose adjustments. Other secondary drivers was that patient follow-up was recorded within the pharmacy, but it wasn't permanent. So if you wanted to go back or if other practitioners wanted to see it, that wouldn't be available. Pharmacist therapeutic drug monitoring is new within SHA, but it's only for inpatients. It hadn't been used for outpatients. And as well, we did have double documenting. So some change ideas were to implement pharmacist documentation on SCM, which is the electronic medical record. We also thought standardizing documentation would be ideal, given that there's evidence to suggest that this improves transitions of care. And then we also wanted to update our internal ward work list. So in March 2022, we implemented a standardized electronic pharmacist documentation tool for patients on vancomycin in the home IV program. We did a baseline chart review just to see what our electronic documentation rates were like for patients prior to being admitted to the home IV program. And we saw that about 20% did have electronic documentation. So we know it is being used. It was just not being used yet in the home IV patients. And so you can see the black line in the center really is when we implemented the intervention. And we can see after that with the orange, by the end of the month, we had 10% documentation, and at the end of April, it had jumped up to 66%. When I collected the data in early May, there wasn't any, it was too early at this point. And so I think we still have room to improve and see if we can maintain our documentation above the 50% target. So key reflections and learnings is that change takes time and it's not always easy. And that's largely due to, as everyone knows, that the healthcare system is very complex and there's multitude of stakeholders, which led into my second major learning is that teamwork is very vital to make sure you're involving stakeholders so that way they can be engaged and motivated to facilitate change. And then it was also a change in mindset with QI. So instead of leading with the solution, lead with the problem and to continuously keep asking why to help with QI. So thank you, everyone, and just thank you to the CQIP program for allowing me to join. And I've learned a ton, so thank you.